Thank you so much for having me. Dr. Bischoff is here, but she said we have such a limited time, we decided it's just going to be me for this presentation. But thank you again to the association for inviting us to talk about this topic. I think it says a lot that it's on such a national platform, an international platform like this. These are my disclosures. So my goal today is to share essential palliative care skills that will allow you to enhance your conversation, communications about complex decision-making with your patients and your families. And if you're a patient or a family, in doing so with your care team as well. Included in that is providing a palliative care definition that you can use when you're referring patients or care partners. And I'll review some examples of models to structure goals of care conversations. And then we'll identify when are the times in the disease to trigger these conversations, because they're not always clear, or we're kind of sometimes unsure about when to bring it up. I will note, I would be remiss if I didn't, that management of complex physical, emotional, spiritual distress is the other half of palliative care skills, but with the time we have today, we'd need an entire seminar on that, so we're going to skip that for today. To start, palliative care refers to addressing total pain, which includes these multiple components. And these components, they impact each other. We've seen that time and time again. Emotional distress is, when that's high, there's a very high level of physical pain. And patients, you can ask them that. Do you feel like there's a component of your anxiety impacting your physical pain? They almost always can identify that. When there's social stressors in place, it affects and threatens their spiritual safety. So they're all intertwined. And we have seen that when we can impact one of these components, we can impact other components and address the suffering of our patients and care partners. These needs, they ebb and flow over time. There are components that may be more severe at certain times. The emotional and spiritual distress at the time of diagnosis may be extremely severe, more so than the physical pain, but then the physical pain later on becomes more pronounced as the disease progresses. And we also see that the shape and the form of the types of stressors, they change over time. But as you can see from this lovely graph, that at all times there's some form of palliative care need that's constant, and that needs to be addressed continuously. And so this model applies not just to that person diagnosed, as we've heard through many of the presentations today, that it also goes towards our patients' care partners and the families and anybody who's really involved in their community or their circle of life. So based on this, I'm going to ask you, when should people receive palliative care? And you'll all say together with me, at the time of diagnosis, right? So there's really no time that you separate out palliative care from the rest of care. But that doesn't necessarily mean that you need a referral to a palliative care specialist. Each of you, every single person, is involved in some sort of palliative care provision because you're actually caring to address their suffering, right? And so everyone is doing some form of palliative care. So this brings me to the clarification of primary palliative care from secondary and specialty palliative care. This graphic was just taken from a cardiology paper, but it applies to all the palliative care models that exist. Primary palliative care is the relief of suffering provided by any clinician not specifically trained in palliative care. Secondary palliative care is provided by clinicians specifically with a specialty in that training. I use the example when I teach the medical residents that you should be able to manage basic hypertension, right? When somebody's needing 1 or 2 medications for their hypertension, that can be done by, hopefully, a primary care doctor. But when it becomes more complicated, then you send them to a cardiologist. Very similarly, every single person that we meet and we train and we work with, and the patients and their care partners and the person cleaning the room, they're all providing some basic palliative skills. When it becomes complicated is when a consideration for a referral to palliative care can take place. So what does a palliative care specialist do? That's often very vague, and so going over some of these might help to give you some categories for what to think about. I've had patients come to clinic and have literally no idea why they're there, and everyone thought that they knew why they were coming, but they had no idea. So as we teach others about palliative care skills, just being here, as neurologists are getting more formal palliative care training, as the neuro-palliative care subspecialty grows in terms of formal training, and then given the limited palliative care specialty resources available, we know that not everyone is going to receive a palliative care referral. Additionally, as you remember from that graph we were looking at before with the waxing and waning palliative care needs, some people will need more specialty palliative care at certain times, and then they may not need them for a while. So I will see a patient early in their disease and then may not see them again for a year and hopefully two, and then things become more complicated again, and then they get sent back to me to do a check-in. So what we do specifically when we see patients as a palliative care specialist, we're trained to sit with the discomfort that uncertainty brings. That is not something that people are comfortable with and not something that everybody wants to do. We can offer different ways to manage complicated symptoms. By definition, palliative care is a multidisciplinary approach. We have usually a social worker and a chaplain and a pharmacist. That's the core of a palliative care team. And that allows for us to address the multifaceted components of suffering that we were talking about. Sometimes we just offer the additional time that's needed for the patient and care partner to provide that support. I have many neurology colleagues who say, I'm trained in palliative care, but I just don't have time. It's not possible for me to address all these needs of their neurological disease while also tending to the psychosocial spiritual needs in a proper way in the time frame that I'm given. We can be a continuity of care across certain settings in the hospital, especially in the US system, there's a lot of rotations of learners in the academic hospital or hospitalists. So sometimes we are that continuity of care for the patient's story. And then, of course, we'll help with transitions to the end of life care. Understanding this fundamental purpose of what palliative care is and what the definition is and what the specialist can do, we can now shift to some of the specific skills that we want to kind of address and that we use when we're really facing a lot of uncertainty and the distress of our patients and care partners. Usually I teach that if you are talking more than 50% of your conversation, you're not listening enough. So listening is the fundamental thing, and I think it's actually a core component of a palliative care fellowship and training that we work on, that we're trained to do. We know from the data that, not to call out my colleagues who are specifically physicians, but in one study specifically, 70% of the physicians spoke over the other people in the conversation. And so we know that when patients and families feel heard, even if they make a complicated decision, they don't regret it later. There are some excellent studies about, for example, tracheostomy placements that the family didn't feel like they really had a choice. The disease was going forward and they had to do this. But later on, when they asked them if you regret the decision, even if the person died after getting that, they felt no regret because they felt like they were heard, they were listened to, they made a decision with that conversation done well. There is passive and active listening. So we'll know the difference with how exhausted you feel afterward. When I have learners on the service with us and we're only seeing maybe 5 or 6 patients a day, they finish the end of the day saying, I am so tired, I don't know how you do this every day. And that's compared to the 12 or 15 that they're usually managing. And that's because it's a skill that takes a lot of work and a lot of patience to sit and do. Passive listening, it's when we're thinking about the next question to ask or the next thing that we want to tell the patient or how we're going to reply to their statement. We're passively listening. When we're in the moment, listening to what they're saying with active curiosity and our emotions tuned in, not only are we actively listening, but we're taking that journey with them. And that leads sometimes to me not knowing what to say. I'll be so overwhelmed with emotion, or I'll just be genuinely stunned and I don't really know what to say about that. And my patients and families have taught me that that is okay. That's more than okay. And they can feel that real appreciation for your actively being present with them. So the silence that comes from not knowing what to say is something that is another fundamental skill in palliative care. This comfort with silence, that leads to really effective communication, which feels a little ironic, but it's true. So next we're going to talk about the values and what's the difference about values and preferences. So values are the aspects of life that patients find important. Preferences are the choices that pertain to a specific medical scenario. These are constructed from an individual's core values and influenced by multiple factors. When we put our patients' values and preferences together, that leads to an understanding of their goals for their medical care. So if their preferences are not aligned with their values, what do? Then you need to ask yourself if the patient has a poor understanding of the medical problem. Preferences are susceptible to undue influence. The more important question is, what does my patient value? And the complex medical problems demand a greater understanding of our patient values. But eliciting these patient values is not an easy discussion. The patient has to be willing and able to engage in that introspection. Many times, as we all know, people are engaging in their own introspection already. So it's a matter of giving them a safe place, an opportunity, a way, using these skills of just silence and being actively engaged and trust building to allow them to share those inner thoughts. Oftentimes, I will share with patients that these thoughts are not dependent on whether you have a neuromuscular disease or any other certain disease. It's just inherent to being a human being. We have these thoughts throughout. It's just a matter of now figuring out how to share those things in a safe and open way. Serial interviews and conversations using open-ended questions can really help them engage in these explorations. So questions like, as you look to the future, what are you hoping for, or what are you worried about? And then you follow those up using open-ended questions of why or tell me more to help them explore that further. In more difficult cases, when capacity or introspection are limited, answers can be inferred from a patient's behavior over a course of their life. And this is where we go back to understanding their values, because if they're their core values, they've been consistent. And many times when we can't talk to the patient, we often ask the family, is this different or is this new from who they are? Who they are fundamentally is the most important part that we're trying to get at. I have learned that the genuine curiosity in understanding how a disease threatens somebody's quality of life and core self is truly what allows individuals to feel safe enough to explore their values and preferences. So it's just going in with a true, genuine desire to understand what this person is living with. Their preferences can change over time, and maybe not even can change, but should change, because they're influenced by experience. The graph we were talking about earlier with the waxing and waning palliative needs, that reflects their preferences, because their preferences reflects their needs. I've had patients say at the time of diagnosis that they're completely unwilling to live with the feeding tube, and then when the time comes to actually make that decision, of course, they have a pretty good quality of life, they've experienced more of the disease, they end up agreeing to having one placed, and that's expected and appropriate. It's not a failure, it's not a lack of conversation, it's what should be happening for them. Of course, these conversations, they come with the delivery of bad news, and bad news is bad news. That's just the way it goes. I remind myself that no one personally, not myself, not the patient, no one is creating this bad news. We're all like deliverers of this message. So I will often use the phrase, your disease is making the decision for you or for all of us. That helps me with some of the guilt and fear related to giving the bad news. And data have shown that patients and care partners can be confused when we sugarcoat or are vague in our delivery. We do not have to be mean, cold, or curt when I speak to patients about this, but if you are just communicating all data and no breaks for emotion, that makes a bad combination. I have literally seen patients crying while the clinician is talking and talking. I had a team once literally back out of the room while the patient was crying. Palliative care will come in and take care of this for you. So it's better to give 1 or 2 pieces of information, even if it's incomplete, attend to the emotional, spiritual needs, and make a follow-up appointment if time runs out. This is where those skills really come into play. I'm almost out of time, aren't I? Okay. I'll just share that these are a set of specific skills that I think can be really taken away. One of the things that I think would be to highlight is asking permission from patients before you just continue on with information. I even use it to give permission, to ask permission for when I'm giving a recommendation. It really allows for a lot more partnership. And the last couple of slides I'll share with you is that these are examples of programs that are out there that have organized ways of providing serious illness conversation protocols. And one that we use at our institution is, as you can see, really heavy on talking about the patient's story, where they really, we have the patient and the family talking about who they are for the majority of the time. And in fact, sometimes that's the entire conversation. Then we'll come back to the medical pieces later on. So palliative care skills are, everyone's doing them. They're for everyone. Values are supposed to be constant, and preferences do vary. When we're talking about the primary skill of listening, of conversation, it's listening. And we want to think about developing our different models that can be used when we're guiding the conversation, because one size doesn't fit all. I'll just put up a few thank yous, and thank you all again for the opportunity.
Thank you so much for your really interesting presentation. I always thought that we did neuropalliative care, and now I've discovered it's got a name. We do primary palliative care.
We're doing primary neuropalliative care.
I'm very happy about that. It's a good concept. I'm just going to check if there's a question in the online. Shall we ask that first?
Thank you. I'm going to start with a comment from Rebecca Coulter with the ALS Association, who says, it's been encouraging to hear more and more about the importance of integrating palliative care over the last couple of years, given the value add. Unfortunately, in my experience, it's not widely available to people living with ALS. Would love to see these programs grow and expand to increase accessibility. And as a person living with the disease, I can't agree more with that. I found it super helpful in my case. The question comes from Lynn Braumeier, who's a person with lived experience, who asks whether U.S. Medicare covers palliative care.
Yes. So in the U.S., a referral to a palliative care doctor or specialist or team is really just like a referral to any other specialist. So the payment and reimbursement should be exactly the same as if you were getting referred to a neurologist.
And will that carry into hospice?
Then once you translate into hospice, Medicare covers all of the hospice care. So then palliative care becomes hospice care. And while if you think of it as the big circle of palliative care and then a small circle of hospice within palliative care. So the programs will call themselves palliative care and hospice care, but when you transition into hospice, that the kind of focus of hospice care is completely covered by Medicare.
We just got time for one question in the room.
Hi, Ambereen, it's Allison.
Hi.
I always love hearing you talk. Question for you, I was taking pictures of some of your slides because the information on it seems so applicable to everything we all do, but from a caregiver perspective and impacted perspective, palliative seems final. So is there any thought of taking these concepts to the bigger picture, maybe the entire ALS experience rather the end?
Yes, absolutely. So that's why I think the hope is that having platforms like this and other platforms where we're starting to teach everyone how to do palliative care early on, then it doesn't need to be an isolated thing like, okay, now you're in palliative care. In fact, there's no such thing as you're in palliative care, because actually to that question, it's congruent, it's consistent when you're getting palliative care. It's alongside all the rest of the ALS care you're getting. So the hope is that it's no shift majorly, and that you're starting to receive components as a care partner and as a family of palliative care from early diagnosis. And sometimes people need a little bit more training, or they're not really sure how to do it or do it well, but the kind of also the reassurance that what you're doing, what the neurology teams and the non-palliative care specialty teams are doing, you're doing it. So just keep doing it is really a message that I think while we're always trying to do better, sometimes we forget that we're actually doing it as well as we can right now with the skills that we have.
Thank you very much.
Thank you.